All right, here's lesson 21 on sepsis and septic shock. Much shorter lesson than our last one. A little bit of work to do online, and we'll run some cases in lab. And we like to connect these septic patients to our respiratory cases as well. Talk a little bit about the physiology, causes, and septic shock assessment and treatment. So physiology, as I mentioned in the previous lesson on respiratory, sepsis patients, it's a distributive type of shock. There's too much peripheral vasodilation. The container got way too big for some reason. Now, we previously talked about anaphylaxis. We talked about neurogenic shock. And so now this is the other distributive shock. So why is that a big deal? If the peripheral blood vessels dilate, who cares? Well, that means that there's less blood coming back to the heart. Reduced preload. As there's more space in the vascular system, particularly on the venous side, those veins dilate, the venous side dilates, you have venodilation, and so venous vasodilation results in less blood returning to the heart, reduced preload. So your heart can only pump out what it gets in. If it's getting less in, it's going to be able to pump less out. So the stroke volume of your heart drops due to reduced preload. So that's one thing. And then your heart rate needs to increase to try to maintain that cardiac output. Remember, cardiac output is heart rate times stroke volume. It's the number of times the heart beats per minute times how much it pumps with each beat. That's cardiac output. So if your stroke volume's down, your heart rate's got to go up in order to maintain. If your heart rate comes way down, your stroke volume will have to go way up to maintain. Well, in this case, the problem starts with the vasodilation. The container gets too big. Preload drops, stroke volume drops, heart rate tries to come up, but you know it can only go up a certain amount. There's a point at which your heart's beating too fast to really fill efficiently, and so maybe between 100 and 120, you're getting some increased cardiac output as the heart rate increases. But when you get up in the 130s and 140s, you know, you can go faster and faster, and you don't get much more cardiac output. So your BP is going to drop due to the vasodilation, and that cardiac output's got to go up a whole bunch in order to maintain. And you know what? It just can't in sepsis, because sepsis is a massive system-wide full-body infection, and it triggers this very complicated chain of events. But basically, here's what happens. You get vasodilation, which then, as we just said, reduces preload, reduces stroke volume. Cardiac output has to go up by increasing the rate and trying to increase that contractility in the squeeze, but the sepsis directly smacks the heart too. So sepsis is mostly a vasodilation problem, but it's also a little bit of a smack to the pump, and you have a little bit of reduced cardiac contractility. And then you also get these tiny leaks in the microvessels, in the capillaries, and so there's a little bit of fluid loss as well. So the patient has the correct amount of fluid in their body, but it's not in their blood vessels. It's leaked out of the blood vessels into the tissues. So you have some swelling, and they're low on volume, and their container's too big, and their pump's not working right. Well, no wonder septic shock's a big deal. So what causes septic shock? Well, it can be an upper respiratory infection. That's possible. It can much more likely a lower respiratory infection, a bronchitis or a pneumonia. Urinary tract infections are a common cause of it. And then it can even be weird stuff like an infected tooth or a skin source, or just who knows, anything that causes an infection. And in a person with kind of a compromised immune system, it doesn't take much of an infection to really kind of kick them in the pants. And so think about a patient who's in long-term care, a patient who's not up and around and moving around. And those patients that are in long-term care, whether it's at home or in a long-term care facility, that are pretty well bedridden or mostly bedridden, they're at risk for pneumonia and urinary tract infections all the time. And so those are very, very common causes of sepsis. How will you know if your patient is septic? Well, he might have a fever, and that would make sense. Because if you have a massive infection, wouldn't you think you'd have a massive fever to go along with it? And that's usually the case. However, it's not always the case. Sometimes they actually have a low temperature. And that's kind of a warning. when your septic patient has a high fever or has a low temp, then they're pretty sick. Then there's also the history of an infection source, and that may just be their presence in long-term care with an indwelling catheter. A urinary catheter is basically a pathway for bugs to walk into the body. So it could be that that's the history of it. It may be, well, he had pneumonia last week and he was on antibiotics and just been getting worse. They're going to be hypotensive. That's the shock part. They're going to be hypotensive, and then their pressure is not going to be 80/60. It's more likely to be 80/20. So why would that be? Why would they have a wide pulse pressure? Pulse pressure being the difference between systolic and diastolic. Why would that pulse pressure be wide? Well, because there's just not much pressure in the system all the time. Remember, the diastolic pressure is the pressure in the system all the time. Well, if it's vasodilated, then the pressure is kind of reduced. And so you may find that wide pulse pressure, but they're going to be hypotensive and they're going to be tachycardic, as long as they're not taking some medicine that's governing their engine. Remember, beta blockers, medicines that end in OLOL, like propanolol, atenolol, metoprolol, labetalol, and there's probably esmolol, there's probably some other olols, OLOLs. Those are beta blockers, and they keep that patient's heart rate from increasing, and so he can't really mount that increased heart rate to help with cardiac output. And so the beta blocker protects him against heart attack and stroke, helps him control his high blood pressure, but when he has a septic shock situation, he needs to be able to go faster, and that beta blocker may keep him down. So these are somewhat challenging patients to assess, and at the BLS level, they're extremely difficult to do anything with other than just supportive care, which means CVO. Do the best you can to oxygenate, do the best you can to ventilate, use their usual treatment for shock, lay them down, keep them warm, give them oxygen, fairly urgent transport. There's not a lot of bleeding going on with sepsis. But just don't expect they're going to get a whole heck of a lot better. These folks can be very altered, have altered mental status, of course rule out blood glucose, but a good measurement of blood glucose, a good measurement of temperature, and blood pressure, pulse oximetry, all those sorts of things. At the BLS level, it's really supportive care. At the ALS level, they're going to do some IV volume enhancement. These folks have very large container, inappropriately large container, and so the basic plan from the ALS side is, if the container is too big, let's fill it up. And if we can fill it up some, or that's not working, then let's try to shrink it down. But the medicines we use to shrink it down are more dangerous. They have more side effects, more cardiovascular risk than just adding some fluid. So your septic patient's going to get maybe 2 liters of fluid, 2 liters of IV fluid, which is a fair amount. So they're almost like trauma patients in that, in some cases, even more fluid than a trauma patient would get, trying to fill up that container. And then they may need to add some meds to constrict those vessels, and then they keep doing what you do. And in some places, you may see some additional lab work done on the field. In rare cases, probably not in our system, but maybe in a more remote area, say a Montana or somewhere where your average transport time is 2 hours to a hospital, then maybe some antibiotics started in the field makes some sense out there. For a while, one of our local services was drawing blood cultures in the field to try to speed up the diagnosis of what is the particular bug that's caused the infection so that they can target antibiotics. I'm not sure if that's still going on now or not. It might have been just a short-term study. But so you may see some of that stuff going on. Doesn't really matter much to us. I just wanted you to know that that's going on. And, that's kind of the way that sepsis is managed. So quick summary, they have hypotension from 3 mechanisms, but we're going to see it as mostly a container problem. Yes, there's some impact on their cardiac pump functioning, and there's some loss of fluid from the vascular space, yes, but we should just think of it as distributive shock, and we should think of, when we talk about shock, there's obstructive shock, so that's a pulmonary embolus or cardiac tamponade or tension pneumothorax. Then there's cardiogenic shock, which is from pump failure, either from a very large heart attack or from just a series of insults to that heart. And so there's a little bit of cardiogenic shock going on with sepsis. And then there's hypovolemic shock, which is pretty obvious. They've lost volume, whether they actually bled it out or maybe they puked it out or lost it via diarrhea or sweat or something like that. And then there's distributive. And distributive is that fourth category of shock, and there's really three conditions in there: anaphylaxis, a severe allergic reaction, and neurogenic shock, where the signals from the brain are not getting to the blood vessels. And then there's sepsis, a massive systemic infection causing vasodilation, reducing preload, which reduces cardiac output, which reduces blood pressure, and that's how it kills. The pre-hospital management is just the start. These folks are very sick and require some high-level intensive care unit therapy, and sepsis is a very big deal, and so we wanted to dedicate a lesson especially to that. So we'll run some calls about this in lab, and we like to tie it in with the respiratory patients. So to prep for the lab, think about how you would assess and treat septic shock, how would you assess and treat cardiogenic shock, and how would you deal with the 6 different conditions that cause shortness of breath. And we'll see you in lab.